able to introduce myself. My name is Michael Bare. Add the other titles later, like doctor, but the name is Michael Bare. I am from the Ministry of Health, specifically the Community Health Department, which is led by our Commissioner, Dr. Upentho George. Doctor is unable to be here or is unable to make it because of the commitments here and there, but I'll briefly represent him. I'll start by allaying the fears we have in this room about community-led monitoring. As ministry, we fully now understand and picked interest in community-led monitoring. We understand that it is very crucial in improving the social determinants of health. And previously, community-led monitoring was siloed. It wasn't so clear because different CSOs were implementing it here and there. Everyone is implementing it. The donors are separate and all that. But then, ministry picked interest and said, okay, we need to look into this. This is something so important for our health system. And the Community Health Department was tasked to come up with a framework. Let me call it a social accountability framework. And this framework was to guide all the social accountabilities in the country. And when I say social accountabilities, that is where we place CLM. So as of now, actually the last 2 weeks, the team from the ministry, the team from TASO, I don't know if there is a representative of TASO here, the team from civil society, they have been in Mayanja drafting what we call a national integrated community-led monitoring framework. The framework has been existing. It is not something new. But this framework has not been integrated. Today we are moving into the direction of integrated services. Some of you have seen at the different facilities. Services, especially HIV and TB, have been integrated into the chronic care. So it is something that we are going to move forward with. So I would say the National Integrated Monitoring, Community-Led Monitoring Framework is going to be a policy that is going to guide all our implementations in the country. Because CLM is not implemented by one CSO, by one funder. No, we have different funders and we have different donors. So when we have a standardized policy, or when we say CLM should be standardized, it means we must have a policy that guides all the implementation, and that is the framework we are talking about. Personally, I was there in Mayanja among the people developing that policy. And this workshop was opened by our commissioner, Dr. Upentho. Why CLM? We should be answering that question. Why ministry is picking up this? We have realized that the efforts, they are so good, by the way, but they have been fragmented. And they have not been using what we call standard indicators. We have the national standard indicators, especially in health services. But you will realize that everyone is coming up with their own indicators, their own tools to implement services. So we want this to guide the implementation. It will be standard. If we are talking about going to a facility, there will be standard indicators that we shall be basing on to do the monitoring. And we shall see that this will help to address the social determinants of health while ensuring prevention, care, treatment, and social support services. Also, the previous efforts have been so much on HIV and TB. But like I said, the direction we are taking is integrated services. That means even the direction of CLM is going to be integrated. We shall be looking at all the disease areas, malaria, chronic diseases, all the disease components you know, they will be monitored. And that is what we mean by the word integration. Some of the lessons learned we've seen over the past implementation is CLM showed that community-led data collection improves the relevancy and the credibility of evidence and reveals issues often missed by institutional monitoring. You will agree with me, as ministry, as service providers, we focus on numbers. That we have this number of people who have missed appointments. But then we don't go deeper to find out what is actually the root cause of the missed appointments. So we realize this model is so important, and among the lessons learned from the previous people who have implemented CLM is the voices that come up from the community showcase or tell us that we are missing as service providers. What is it? The recipient experience, all what we call the lived experience. We are providers, we are not living with that particular. Okay, some of us might be, but for us, our aim is provide services to be available. But now, there is this voice from the service recipient, what UNAIDS called the recipient population or service user. The service user is telling you, you know what, you're giving me ARVs, and when I go home, I put them into, or I bury them somewhere, or I give them to pigs. This is not a component we are picking as service providers, not so? We don't pick it. So when we get that voice, it helps us improve on the indicators that we are monitoring. Then the other lesson is the strengthened accountability in health service delivery and improved engagement between the CSOs, the health facilities, and the policy makers. There is need to bridge that gap. That gap has not been bridged, and that's why we've been seeing the differences between the service provider, the CSO, the health facilities. Everyone is coming up with their own findings, and they are totally speaking different. So we would say it will strengthen the accountability at that level to make sure all stakeholders are on board. Then we saw that sustainability requires reliable funding. The chairperson has knocked on it. The fear is it is largely dependent on donor funding. Now, when there is a framework, something I missed to mention is after this development of a draft, it will be presented to the HIPAC. Do we know the HIPAC? I guess we know. This is the high-level accountability team that has the PAs. It has high-level people who are going to approve the policy. It should be presented to see actually if it is really relevant to our context. So this framework is going to be presented, I think, next month, March. And we shall be able to erase, let me use that word, the fears of the funding. It means ministry will take full accountability. It means ministry will also help us in resource mobilization in the country. Isn't that something good enough? So other than the donors coming here and there, it means even ministry will be fully involved in the resource mobilization, and that means it will also take part in the funding of the community-led monitoring. Well, we also looked at the strong data governance systems which are needed to protect integrity, confidentiality, and ownership. We are using different health management systems. Some implementers are using DHIS2, others are using ComCare, others are using, I think it was UK something. These are different. Now, we have a component of data security. Where is this data going that we are gathering or collecting from the service recipients? All that will be in the policy. But it is something like a lesson learned over time and contributing to the development of the framework. We also saw that CLM success depends on collaboration. Without collaboration, there is no way. The reason why we are here is because Dr. Mayanja wants all partners in here in a collaborative manner so that we improve on the social determinants of health for improved health outcomes. That is a message from the commissioner, not my words. And allow me for now, it's about relaying your fears and assuring you that Ministry of Health is fully committed to supporting community-led monitoring all over the country. You also forgive me, I missed the protocols, but allow me ride on the existing protocols so that I don't make any mistake. Thank you very much. Thank you everyone for coming. I'm seated there and I'll be listening in.
Yeah, thank you, Minister of Health. Thank you, Dr. Mike. From the horse's mouth, whatever we are doing here, whatever we are implementing down in our districts, we are feeding into the national strategic plan, but improving what Ministry of Health decides for all of us. So take our regards to the Minister. We go to our next session. Before we go to the next item on agenda, we have our colleagues that have joined us. Maybe we can have just a few minutes of introduction.
Thank you so much, Timose. All protocol observed. My name is Andrew Saja. I'm the Executive Director, Department of Possibility in Isingiro District. We are centered in Nakivale Refugee Settlement. And we are one of the community-based organizations championing CRM in Isingiro. Thank you.
Yeah, give him a hand clap. The link I was telling you, the live broadcast, we have already sent on WhatsApp. Please share it back in your district. Saturday, listen in. They see whatever is taking place. The team from Bara City had also not arrived. Let's hear from them. Introduction.
Yamwisha Immaculate. I'm here representing the service users.
Morning team, all protocols observed. I'm Tegeki Paul, working with harm reduction and productive health initiative. Thank you. One of the organizations that are implementing CLM.
You're not clapping. We are in the city. And the city is here, so everything is covered.
Dr. Muchaki Ruche, City Health Officer.
Thank you.
Dr. Twinavitu, I'm City Health Educator.
About CRISPR, Team Leader Harm Reduction and Reproductive Health Initiative, CBO, implementing CLM in Imbara City.
Good morning, everyone. I'm Aisha Belton from TYI Uganda, also implementing CLM.
Okay, thanks, Mbara City team.
Good morning to you all. All protocol observed. I'm Wasuba Shaban for City Town Clerk. I wish you the best in this meeting.
Good morning, everyone. My name is Joseph Biarugaba, a district-based program officer supporting Ntunga, Mawasheni, and Shema. I work with Mayanja Memorial Hospital Foundation. Thank you.
Okay, thanks team. Like I told you, we are sitting in districts.
Thank you. I'm Ambrose Tsime, DCD on Tungam.
Okay, thank you. We have 6 districts, 5 districts and 1 city. But in total there are 6. Mbara City is here. We have our colleagues also from Kasese that had not come.
I'm Bira Zainab, CLM monitor from Kasese, Nakola. I'm Bira Alice, a TB survivor.
I'm Tom Justin. I work with Nakola as a monitor.
Morning team. I'm called Wambala Paul Mujungu from Great Lakes Peace Center, an organization that has had its partnership with Nakola. Thank you.
Morning team. I'm by the names of Muhindo Morris, project officer Nakola.
Thanks team for introducing ourselves. Another introduction, briefly listening to this one.
I think it would be okay if everyone introduce him or herself so that everyone can watch, or the person who is online can know who is here. Thank you. It is Fatwest TV. You go there and you check whether on YouTube, X, everywhere, it is there.
That is our service provider for Fatwest TV that is taking us online. So make sure when you're here, you participate so that the people outside can see you. After, you will also see this video after you keep on seeing yourself. So for those of us who are from very far, we are now in the city. These are the beauties of the city. So we may not maybe repeat the introduction, but specifically we have 5 districts representing and 1 city. Here is a team from Rwanda. Maybe you can just wave. The team from Rwanda. This is a team from Rwanda. Let's clap for them. Each district is represented by 12 participants. Like I had said, we have the CAO, we have the district health officer, DHO, we have the biostatistician, we have the DCDO, community development officer, then we have 2 representatives from the CBO, civil society organization. We have 2 network representatives. We have 2 service users and 2 what? I had already said these things. 2 CRM monitors. So each district has 12 participants. This is Rwanda team. Kasese team, move to the team. And you also clap for them. So you're going to see a district that didn't represent with all the 12. But don't laugh at them. Rubirizi team, wave to the congregation. Yes, Mbara City, let's wave. Mbara City, let's wave. Okay, thank you. Ntungamo district, let's wave. Okay, and then finally, Isinjiro district, let's wave to the team. And then we can have Mayanja Memorial Hospital Foundation team wave. Okay. Thank you for coming, and let's actively participate in this meeting. We are going to our session for presentation, and the team had requested the chair of the session as the DHO Tungamo, Dr. Amon, to take us through.
Ladies and gentlemen, good morning. First of all, let me first introduce myself. I'm called Bahati Amon, and I'm the District Health Officer, Tungamo. We're going to go through this small session, but I would love to first give you small announcements. One is that for us who have just entered, tea is served at the back or on the entrance of this hall. Still on the, as you move out, on your right, there is a walkway to the washroom, but also on your table, you have a Wi-Fi password. We are going to have this session very brief, and I will request the presenters to keep time. Ladies and gentlemen, we are going to have overview of this presentation. As you can check on our schedule, we are going to have objective and the scope of this CRM, but also here the participating districts and CBOs, and I would love that you pay key interest. Then we are going to also have CLM methodology, which includes planning, data collection, analysis, feedback, and advocacy, etc. And I know you are very comfortable with this. Lastly, we shall have key service delivery gaps identified, and this is what you need to note down so that you know which gaps are identified in our districts. We shall also learn trends, progress, and persistent challenges, but also we shall also hear community voices, particularly those selected service users, share their experience. And since we have them here, we shall be glad to learn. And lastly, we shall have a plenary session where we shall reflect and cross district patterns. And thereafter, we shall have question and answers, as brief as that. Ladies and gentlemen, permit me to thank Mayanja Memorial for having organized this function, and I would love that you stand up, particularly the person going to present, and you first tell us, particularly for some of us who have just come, want to be comfortable with the objective of this CLM. Thank you. Mayanja, you're welcome.
Yeah, like Dr. Mayanja said, and like we all know, community-led monitoring, this is our own communities implementing, not specifically Mayanja. So these sessions are going to be taken through by us, you, not us Mayanja. So we have our own from one of the civil society organizations in Ntungamo, Support Disabled Uganda. I think he's going to introduce himself, and then he's going to take us through this session. Thank you.
Thank you so much, Timothy. Dear members, allow me adopt the protocols as we proceed with I work with Support Disabled Uganda as the head of programs. For the interest of time, I'm going to take you through the in-depth of what we do
what all CLM is, for you to understand the far we've gone and where we are. To mention, so far I think we had gone through the goal of this meeting as to strengthen accountability, effectiveness, and quality of health service delivery by institutionalizing regional dialogue platforms that translate community-led monitoring evidence into coordinated, measurable, and actionable system improvement. That is clear. It is all about the community owning the services and demanding their rights. Team, you can go to the next. The objectives of this meeting are very clear. We have gone through them, and one is to systematically present and critically review evidence and insights generated by community-led monitoring. We also want to strengthen collaboration, and maybe Tim, I can have the piece here. It is not that good to focus that side. Yeah? Yeah? Let me be here. Yeah, to strengthen collaboration, trust, and coordination among communities, health service providers, duty bearers, and other stakeholders. 3 is to identify, prioritize, and consolidate unresolved systemic and structural issues that cannot be addressed at the community or facility level. Here, you understand that we normally, after getting the data, we analyze it, we give feedback. But some issues couldn't be solved at a community level and even at facility level, even neither at the district level. Thus, now the region having this objective of we identify and prioritize and consolidate the unresolved systemic and structural issues that cannot be addressed at those two levels, the community and the facility level. And lastly is to document and share best practices, innovations, lessons learned, key achievements, and implementation challenges emerging from CLM. This is an opportunity for us as districts, because we are meeting for the first time to share experiences, challenges, lessons, because Tugam what did, what Kasese did, or what went to Mbara City, we are here now to share. This is a consolidated report that we can all learn from one another at the district. What is it all about? The simple definition, or how do we understand by the CLM, the community-led monitoring? It is the mechanism that service users or local communities use. Now these are our daily people, you know, our local people at the community level. The mechanism they use to gather, analyze, and use information on an ongoing basis to improve access to quality and other impact of services, and to hold service providers and decision makers to account. Our service users and other community members have the rights to engage with the service providers and even the leaders on the better service provision. Mayanja Memorial Hospital Foundation, so far this is what the region has reached. 1, operation is in 6 districts, as you heard them, Timothy introduce. We are operating in 48 health centers. These are 8 centers per district. The number of respondents so far reached, the beneficiaries are 2,845. These people were reached in the period of January to December last year as our respondents, both key informants and during focus group discussions. Then health workers reached were 367 across board. These are the health facilities that we have implemented through per district. In Rwanda district, we are operating in Muko Health Center 4, Bufundi Health Center 3, Hamurgwa Health Center 4, Ruhija Health Center 3, Ikumba Health Center 3, Mpungu Health Center 3, Bubare Health Center 3, and Bindi Health Center 3. Then in Isinjilo, we have Dwekubo Health Center 4, Chunjezi Health Center 3, Mabona Health Center 3, Nachivale Health Center 3, Rubondo Health Center 3, Charumba Health Center 3, Chihengo Health Center 3, and Juru Health Center 3. In Mbarara City, we have Bihargo Health Center 3, Kamkuz Division Health Center 3, Health Center 2, Mbara Municipal Council Health Center 4, Kakoba Health Center 3, Nyakayojo Health Center 3, Nyamitanga Health Center 3, Nyamtobora Health Center 2, and Ruti Health Center 2. In Rubilizi, the health centers operating in are Butoha Health Center 3, Katerera Health Center 3, Kichwamba Health Center 3, Chabakara Health Center 3, Chenzaza Health Center 3, Ndagaro Health Center 3, Munyonyi Health Center 3, Rugazi Health Center 3. In Tungamo, we have Itojo Hospital, Chitwe Health Center 4, Ntungamo Health Center 4, Gwashamie Health Center 4, Rubare Health Center 4, Nyachela Health Center 3, Chamasha Health Center 3, and Ngoma Health Center 3. In Kasese, we have Kasese Municipal Health Center 3, Hima Health Center 3, Nyamirami Health Center 4, Katunguru Health Center 4, Muhocha Health Center 3, Rukochi Health Center 3, Bugoye Health Center 3, and Katodova Health Center 3. Members, the main objective and the goal is to improve the accessibility, availability, and quality of HIV, TB, and malaria-related services. This is the main goal. To improve the accessibility, availability, and quality of HIV, TB, and malaria-related services. It means if we don't look at all these, or if we don't achieve these, then we are out of the goal, or we haven't achieved our goal. Because the main issue is to improve how people are accessing the services, the availability of the services, and the quality. Basically, we're looking at HIV, TB, and malaria. Going to the next, I want to also bring to you our methodology, how we do. How does it work? How does CLM work? One, we begin with the planning and prioritization. This planning phase is not only done by individuals, but is a team. For example, the district health team, the CBO's team, and the Biostat do a lot during planning to look at which facility needs this service more than the other. So this is now the planning and prioritization. We don't impose that we go here and there. No, we are guided by the indicators as from the biostats. Then after getting this planning phase, we go to data collection. On data collection, each CBO has 2 data collectors who do this work. They were trained by TASO, they are professionals, and they have all it takes to collect quality data from the community. They were given tools and how to use them. It is a system-based data. So once they collect this data, on the 3rd phase, this data is analyzed and validated. The data analysis is done by both the biostaticians, it's done by the monitors themselves, and also the facility technical team in charge or other health workers, and a few community members who gave this data to accept and approve that yes, this is what we saw and we got from during data collection. That is during data analysis and validation. And then we give feedback. Feedback meetings are categorized into 3. One, we have the feedback meeting with the community members from whom we gathered the data. We go back to them, we meet them and say this is what we got out. If there are issues that can be handled at the community level, now community members take them up to act from there and then. And then the issues they cannot handle at the community level, they are escalated to the facility level. Now at the facility level now, the composition is the health team members at the facility level, the HUMIC members, the sub-county leaders, maybe the chairman of C3, the sub-county chief, maybe the councillors for health, and other stakeholders at the sub-county level. Now, these people come at the facility level for this feedback meeting. Issues that are discovered at this level, they are discussed, and action points are made there and then, what they can handle. And then, what they cannot handle is escalated to the district for a district feedback meeting. Now at the district level, that's when we have the district team, the DHT team at the district level. We also have the councillor in charge of health at the district level. We have the chairman of C5, we have the RDC, we have the CAO, we have and also stakeholders, the CLM stakeholders. Each district has a committee. We have what we call steering committee for CLM and also stakeholders. These people also come to the district, and also all the in-charges of the health facilities where we picked the data are involved in this meeting for a district feedback meeting. At this level now, the district is able to discuss the challenges and the successes and areas that need concern. They are taken up and action points are made and timelines. This is the detailed methodology which I've been explaining, the facility selection, how we selected the facilities. Down, we are looking at selection of the monitors, how the monitors were selected. They were selected by the community members during a steering committee meeting and stakeholders engagement. CLM monitors are not staff of CBOs that are implementing. They are community members. Because even in the absence of the CBO, we believe these people have been trained and have all the knowledge, will proceed doing their monitoring activities and can escalate issues found out. So they are not staff of CBOs, but they are community members, and they were selected by their fellow community members to represent them to collect data. Then we have training of monitors. I mentioned about it. They were trained on how to correct the data. We also have data correction and how it is done. I talked about it. The data analysis, I talked about, and reporting, how the findings are analyzed jointly, and the gaps and barriers and improvements are jotted. The community feedback meetings, I talked about it also. Then facility and district level feedback meeting, and also monitoring and follow-up. Actually, the CBOs, their major role is to monitor if this data is really being collected accurately. The CBOs, maybe the executive director, maybe other part of it, they follow up these monitors to see what they are doing in the community and the data they are collecting and it. And each level now, at a community level feedback meeting, there are advocacy issues that are addressed there and then. And then at a facility level feedback meeting, also, there are advocacy issues that take place there and they are taken there and then. And therefore, also at the district level, the advocacy issues that take place. So you realize there is the CLM, majorly part of it is advocacy. We advocate for the better services and the availability. Members, allow me bring to you the key findings during this process and the proposed actions. These are critical in this meeting as we are here. One of the findings is that 294 out of 2,847 respondents, that is 10% of the beneficiaries, reported lack of privacy and confidentiality, especially in art clinics, ANC, and pharmacy dispensing points. This is now at the regional level, we are discussing it. This was critical. Percent reported having no privacy and confidentiality during art clinics, ANC, and pharmacy dispensing points. That's one. The second is clients feel exposed and unsafe, which undermine trust, dignity, and confidence in health services. This is very paramount. Clients feel exposed, and which is not good, I think. 3, this contributes to reduced service uptake and poor community and poor continuity of care. They fear, they shy away when they don't get privacy in addressing their issues when they come to the facility. The third is you realize that though many respondents are aware of services like HIV, actually 91%, that was HIV, TB 77%, and malaria 90%. There's awareness of essential health services remains. For instance, 25% of respondents were not aware of GBV services, sexual rights, human rights, SRHR, newborn and child survival, 26%, and nutrition, 34%. This limits the ability of the clients to make informed decisions and access service on time. There is reduced refill duration for essential medicines, that is art. Short refill periods for art and other essential medicines force patients to make frequent facility visits, creating financial and time burden. The challenge is worse for rural, hard to reach, and refugee hosting communities, especially in Nakivale. Consequences include high transport costs, was reported by 693 beneficiaries, lost income, long travel times, and increased risk of treatment interruption. This is clear that when they keep moving for refill to the facility, sometimes they have no money and they miss. Another big issue that was found out is persistent long waiting times or hours at health facilities. 63% of beneficiaries, that was 1,705 people out of 2,847, reported long waiting hours as a major barrier to accessing quality care. You go to the facility, you wait. You reach there at 9, you go back at 4. Effects include delayed treatment, reduced follow-up visits, loss of trust in health services, compromised quality of care, and increased reliance on informal providers. Lastly, low awareness and ineffective feedback systems. Ineffective feedback systems. 39% of respondents were unaware of complaint channels and existing mechanisms, e.g. suggestion boxes, digital platforms are often inaccessible. Those that are available are poorly managed or exclusionary, undermining trust, accountability, and service quality. Limited operating hours, restrict access. Many facilities, not some, not even a few, but many facilities open late. They close early or remain closed on weekends, limiting access to essential services and undermining trust, continuity of care, and confidence in the health system, especially for urgent needs or emergencies. There is critical staffing shortages in many health facilities. This has been most pronounced in delivery and counseling services following the withdrawal of some donor support, as well as in laboratory services, specialist care, and dental services. 2,248 out of 367, that was 68% of the health facilities staff, affirmed these staffing shortages. Abashahot bariyo. There are very few, they are inadequate staff. Actually, some of them were at 38% shortage, leading to now long waiting, one person serving the queue, hence a big challenge. There is also inadequate staff accommodation. These are factors hindering the quality care and services. This forces health workers to travel long distances, as reported by 197 out of 373 facility staff. This contributes to fatigue, absenteeism, and delayed services, highlighting the need to prioritize housing near facilities to improve service accessibility and efficiency. There are some recommendations that have been proposed. Probably, if they are taken up, they can help. One, there is a need to prioritize establishment and improvement of appropriate physical infrastructure, service flow arrangements, and privacy enhancing. This is critical. We need more infrastructure. for privacy issues and also making the clients feel comfortable to disclose. Next is they need to strengthen client education, community sensitization, and structured health talks. We need to revitalize the community outreaches and information dissemination systems. These outreaches are needed also to be scaled up so that we reach communities to their accessibility. There is need to scale up differentiated service delivery models, including multi-month dispensing, community-based refills, and decentralized distribution is to improve adherence and the continuity of care. We give them like maybe 3 months or even 5 months or 6, at least so that they can take longer without coming back to the facility. There's need to strengthen the health system through improved staffing, better patient flow management task, shifting appointment systems, and differentiated services delivery models to reduce the waiting times and ensure timely, dignified, high-quality care. At the triage, let people be directed where to go. People come and stand even when he needs the service this side, but he's new in the long queue because he or she doesn't know where to go, what to do. So at the triage, there's need to have maybe like volunteers to keep directing people on what to do. There's need to enforce mandated operating hours, establish emergency or on-call services, engage communities in scheduling, and regular monitor compliance through supervision and reporting mechanisms. Urgent cases. Urgently, we need to assess staffing needs, mobilize resources to fill donor-related gaps, and deploy, reassign, and build capacity of qualified personnel to ensure consistency, quality, and timely healthcare delivery service. They need to provide adequate staff accommodation near health facilities to improve staff availability, reduce fatigue and absenteeism, and enhance timely and quality care of service. These are a few of the achievements of the CLM. 1, service providers through direct engagement. There has been increased awareness, at least we have achieved this. There is increased awareness among communities on health rights and available services. We applaud that, which is very good. 2, train the community monitors in data collection and reporting. These people are there and they can be used at any time. 3, there is improved attitude of health workers towards clients. Clients at Dwashamire Center 4, Rubale Health Center 4, among others, have reported improved and respectful care at maternity and other services. When you look at that first picture, that is now that was the toilet at Itojo Hospital, which was defunct, and several others. The washrooms were not working. But after the advocacy meetings with the HUMIC members and the board, now the renovation is taking place, and now there's some good work going on. We thank the project for that success. There are a few challenges that we have come across. 1, there is limited awareness of health rights among clients. Much as we have done all this, there is still limited awareness of health rights among clients. Clients shy away from demanding their rights. Clients still fear reporting delivery to staff. They fear reporting these issues. Some service providers perceive CLM as fault finding rather than improved forecast. The in charges and others say these people are now they are becoming, you know, kalebuzi. You want to see what you are doing, what, you know, and they tend to fear sometimes to give very good hospitality, thinking we are fault finding, yet it is not the case. Inadequate resources to implement actions agreed on in feedback meetings. Yes, we say there are inadequate staff. If the staff are working at 23% or 38%, even the district say, we don't have the wage. What do you want us to do? So these are some of the challenges that we've been meeting, inadequate resources to implement the actions agreed in these feedback meetings. Competing priorities are making key duty bearers miss out on these meetings. You target probably a very highly profiled person, maybe the cow, maybe the DHO and others in the meetings, and this is the same day probably they have a council meeting. Or maybe they have a travel, they have this. You find some of these meetings, they are mostly the key owners delegate. And when they delegate, at times the delegatee may have no full authority to make a decision. So these are some of the challenges that we've been going through during the implementation. So these are some of the photos. We hope you will share this presentation. And thank you so much for listening. May God bless you.
Thank you, our presenter, Mr. Saimana, and representing SDU very well, particularly on this presentation. Ladies and gentlemen, you've heard, and I would love that we go to the next item on our presentation, and permit me move to preliminary discussion. And since we've all taken note, I would love that we go to question and answers, and we say bye to this session or presentation. Ladies and gentlemen, maybe what I heard you presenting, you said our district called the Rubirizi has Rugazi Health Center 3. Is it a 3? Maybe Decho will tell us. Is it a 3 or a 4? Yes, but in the discussion I saw Health Center 3. Maybe it was a small typing error. So can we have maybe question and answers? Some of us who have something to complement or ask, then we are going to give it 5 minutes.
Okay, please there is a hand behind. Thank you. We shall have our hands up, and then I can bring you the microphone, and they can be questions, they can be comments, but after this session, we shall have sharing of experience from the service users, and these people can prepare after. Taremwa Albanias from Isinjiro, Mabona. Bira Aris from Nakora, Kasese. And Rabsinde Vicent from Rwanda. We shall give you an opportunity to come here in front and share experiences on how you've used the service and CLM. Thank you. So you put up your hand and then we can get to you.
Thank you so much, the presenter. My issue is about privacy. Yeah, it's true there may be lack of privacy in facilities, but with the current mode of integrated clinical health service, with the era of integration, we are really emphasizing privacy, and as we talk now, facilities are emphasizing dispensing rooms instead of dispensing spaces, especially in the chronic care clinics. And also we are emphasizing dispensing rooms instead of dispensing windows. And I think this, in a way, has improved on the privacy among the service providers and actually to our clients. Thank you so much.
Thank you. Another one? Shall have around 5 hands.
Thank you very much, and thank you, the presenter. It kept coming in my mind as, because the reality at the community, we have issues around prevention, and we are all looking at ending HIV by 2030 amidst all the challenges that we have as a community. But in your presentation, I didn't see issues around prevention coming out, whereby we have issues around PrEP, we have issues around stock out of condoms and the self-testing kits. Should I think that among the communities that you had or you met or you interviewed or you talked to, there is no one who needed a prevention or had issues around prevention? Because the reality is that we have issues around prevention in the community, and I'm not seeing them captured. Even issues with KP service delivery, like no peers at the facilities, which has brought KPs running away from service delivery. I'm not seeing things around that captured in you.
Thank you. When you get the mic, tell us your name, and then you ask perhaps even where you're coming from, so that we know each other.
Dr. Shakirucha is my name. I am looking at this item, the key finding on information gaps on available health services. I want to relate this one to referral systems. Sometimes most of the facilities do the referrals, but do these clients know where they are going? And do they know the reasons why they are going to the facilities? Some of this information is lacking and actually is wanting. The facilities, the health workers, the clients, and the service providers don't even know where they are referring and why. The clients, they are referred, but they don't know the reasons why they are going. Some of this information is lacking, and our clients are also complaining in such a manner. Why do I have to go from MMC Health Center to referral, yet you also offer the similar services? Some of those information have not been captured in this. I want to thank you.
Thank you.
Thank you. Once again, I'm Chris Paul from Harm Reduction and Reproductive Health Initiative, implementing CRM in Ibarra City. I just wanted to respond to one of the concern that was brought forth. Through CLM, of course, a number of gaps were identified in interaction with the community, giving their concerns and also contributing on the possible solutions that would perfectly work for them as community members. One of the areas that came out strongly was around prevention, and this was looking at limited access to health commodities, especially HIV self-testing kits, lubricants, and condoms. And through the interactions we had together with the community, after collecting the data, then feedback with the community, engaging the facilities, giving the feedback that we got from the community. And we also, the fact that the CLM doesn't work only with the community and the facilities alone, but also the different stakeholders, the office of the CHO, and other relevant stakeholders. Through the office of the CHO, the HIV focal person spearheaded the drive that was locating facilities with big stocks, and also provide a room where they can share with the rest of the facilities that are stocked out. And this was done. A number of self-testing kits were located to some facilities that had enough, and they were redistributed to other facilities, but not forgetting that they're using the right procedures, requesting through the office of CHO. Then on the issue of condom, through using the past barazas that we had, the HIV focal person was able to secure 50 boxes of condoms. And using the community sessions we had, community members also contributed on suggesting where they want these condoms to be put at. And in Nyamichawala, condoms were put at her place. She comes from one of the hotspots, and that's where the organization she aids is. Condoms were put there. In Roti, condoms were also, the space was identified, condoms were put there. In Roharo, the space was identified, and condoms were put there. Nevertheless, the beauty about CLM is that you don't get an issue and solve it and finish and end there and then. No. CLM provides the communities and provide more additional options for how service delivery can be improved. And we are glad that CLM is continuing, and we believe in this phase, that the second phase, other areas were also identified, and through the feedback meetings that we have had together with the facility teams and also the stakeholders at the leadership level, we are going to also have another drive where we expect that the HIV focal person is going to allocate other commodities and redistribute to other spaces that were identified. Thank you.
Okay, thank you, our presenter, and all those who have made reactions. Once again, I'm Niwagaba Gerard, the Principal Assistant Secretary in Tungamo, in for CAO. I want to talk about staffing gaps or shortages, and I will connect it with the wage bill. Well, we appreciate the fact that most of our facilities and districts are understaffed, but some of these issues are beyond our means as districts. Because with the staffing, it needs a lot of resources in form of funds, both the recruitment process and the salary, the wage to pay. For example, if I talk of Tungamo, we acknowledge the fact that we are understaffed, and we had initiated on the process of recruiting more staff, but we later realized that we didn't have enough wage and cancelled the whole process. And securing the funds is not within our means. We need to engage the necessary ministries like Ministry of Health, Finance and Public Service, and sometimes it is a national policy issue. So now that we have the Ministry of Health here, representative, it's a take home. You discuss it, you acknowledge that districts are understaffed and have no way out unless you clear them to recruit more staff, because that's not within our reach and we can't do much about it. Only that available staff are delivering up to expectations. Then two, you talked about clients making several travels to health facilities, and you sort of suggested that they give them some big quantities, especially these who are on art, so that they spend like 5-6 months without going back. But also, these drugs might be mishandled and eventually they become spoiled. You find they are taking spoiled drugs which are no longer useful to their health. So I would also advocate that these community-led monitors integrate in their activities sensitization programs. These people need to be sensitized about how to keep their drugs, about how to manage when they are on treatment. They know, they follow the guidelines. Otherwise, you might give him drugs for a year, and within 1 week, they are spoiled or even powered down. We have live stories about someone who was given some drugs which could take him for like 2-3 months, but eventually they were all powered. Children started playing with them, and powered them off. So he had no drugs for the next period and started sharing with his colleague what he had. So all those issues, we need to increase on sensitization programs so that as we also try much as government and the health facilities to deliver these necessary services to the people, they also help us by following the prescribed way of taking them. Otherwise, we don't share or we don't own the blame alone. There are other players who, if they are not brought on board, we shall not do much. Like he has proposed that this is a continuous engagement. You cannot say today I have told these people what to do and you think you have finished. You need to continue reaching them because sometimes they relax, they forget. Many things happen. So we need to continue engaging here and there so that we deliver to expectations. Otherwise, I want to thank you, Living, for initiating that program of community-led monitoring. At least it helps us to identify gaps and where we can chip in and manage, we can be able to solve some of the challenges. And I'm happy to note that you have brought out that Rwashamire and Chitu Health Center 4, or rather, have registered great improvement. That's very great in as far as Tungam is concerned.
Thank you.
Thank you. I'm Natunda Peace Kachoncho from the Forum Network in Tungamo District. This is the issue raised by presenter. A long time waiting hours at health center. For me, I want to know what brought this habit of delaying clients and which it can result in defaulting by clients. So CAOs who are here, tell us what measures are you trying to put on to make sure that we stop this habit of delaying clients? Thank you.
Thank you. Let's have around the 2 or 3 hands, then we can close this session. Isn't it?
Thank you very much. I'm Talema Albanias from Isinjiro. Mine goes to where the way how the information is passed to a client when has just tested for any chronic disease. Cause in most cases you find that a person gets an information and then gets a stigma, and you find that person can go and do what? And commit even suicide. It is so suicidal that most of the people who are service providers who test, they just pass an information before counseling those people. So I don't know what CLM is trying to do to make sure that service providers or the people who test, that they give the information after those people have already been counseled, not to get a stigma of what they have had. Thank you very much.
Let's have 2 and then we stop the session.
Thank you. I'm Maurice Bambale, DOP in Akivali. The previous presenter about the presentation, one key thing I noticed is that 9% of our clients don't know or are not aware of the feedback avenues. The issue here is these feedback avenues are there. Probably the health facilities have them, but awareness hasn't. Letting their committee members and clients know about them is where the issue is. And remember, if they don't know about them, then it means they cannot be able to air out
or to voice their complaints about the services they receive. And in the long run, the health facility will miss critical client insights needed to improve service quality. So going forward, let the health facility in charges and the committees pass on this information to ensure these clients of ours are aware of the service feedback avenues we have. Thank you.
Yeah, thank you very much. Mine is, I pick it from the person Tungamo, dealing with the staffing, inadequacies in our health facilities. Personally, I acknowledge it, but I want to appeal to local governments, appeal to the ministry. Local governments have currently, last year, undertaken an exercise called Local Government Performance Assessment. In that performance assessment, Ministry health departments were being assessed, and one of the indicators was relating to staffing. The assessment manual took staffing and assessed it using the old staffing norms from Ministry of Health. And when you look at old staffing norms, definitely district staffing position changes significantly well. And therefore we denied ourselves a voice to speak. If we had used the new staffing norms, you would have had a different outcry in the entire country. So, my urge is to chief administrative officers that when government is undertaking an exercise of such a magnitude, will be critical to see what are these. Because they assessed 5 cadre staffs, critical. They assessed clinical officers, assessed how you are staffed in terms of nurses, midwives, people in lab, in theater, and the health inspectorate. And the assessment covered health center 3s, health center 4s, and district general hospital. The report that I have seen, which is not yet presented, indicates at least a different picture when you compare with others. So what is my appeal? That local governments should have insist on the new staffing norms that were issued, agreed with the Ministry of Health, agreed with Public Service in the subsequent. The second area is on our community monitors. When he was presenting, something struck me. What mechanisms are there to protect our community-led monitors from intimidation and backlash, so that really the thing can move on very systematically? The third area is on feedback mechanisms. I enjoyed when you were talking about, the presenter was talking about at community level, at health facility, and then at the district level. The thing that intrigued me is how do we put that feedback mechanism and link it with existing structures. For example, I had a steering committee which is proposed at the district, and yet there are fundamental structures at the district that help us in doing decisions. A TPC, the Technical Planning Committee, executive committees. How are these things that are coming from communities, isn't it, going into those structures that really make decisions and we link it? Then lastly is on impact and the results measurement. I enjoyed the achievement and all that. But if we push it higher, but not for this meeting, what indicators are being used to measure the impact of community-led monitoring? Thank you.
Thank you. We are going to.
I think we are going to listen in to.
Let's give Kau
Rubirizi, and then we had the city clerk also, and I think one representative from the CSO.
Rwanda. This is Kao Rwanda. Thank you, Chair, for the opportunity. I want to start with appreciations. I want to first appreciate the community-led monitoring model. 2, I want to appreciate the conveners of this meeting. And 3, I want to appreciate the report and the findings just presented. The findings are real. And as we are in this room, I pray that we don't apportion blames. We look at the findings, we look at the challenges, the way they are, and we agree as service providers and service beneficiaries, how do we move forward amidst these challenges? Because the report has raised the challenge of limited accommodation. It has raised the challenge of limited staffing. Now, with those 2 challenges, then the rest will be there. I don't want to be a spokesperson of the health people, but if I have limited staff, the person who works the night is the same person it open in the morning. What do we expect as service beneficiaries and service providers? If I don't have accommodation at the health facility, and as we appreciate some of the health facilities maybe are hard to reach and hard to work in, and I don't have accommodation there, what would be expected of me to reach and serve in that facility? It's good that we are with the Ministry of Health in this room. And we also appreciate that the Ministry of Health gave us the new staffing structure, but without the wage to operationalize that structure. And we also have a complaint in the recently concluded assessment, because the assessment manual tagged the performance on the new structure, where we don't have wage to operationalize the structure, unlike how it has been presented, that we used the old structure instead of new structure. The assessment team used the new structure when we needed them to assess us based on the old structure where we have wage, and we would appreciate the findings. So my appeal would be, amidst these challenges and the way the findings are established, the meetings conducted at the facility and the district level, we need to appreciate and agree that the challenges are there. And some of the challenges are beyond us. We cannot say they are going to be solved tomorrow or next year. Amidst these challenges, what can we do to improve our services? Because if accommodation is not there, it is not there. If the staff are not there, I need clearance, I need wage to ensure that I advertise and recruit. Minus wage and clearance, I cannot do the recruitment. How do we operate with the existing staff to ensure that people are served? My appeal would be, our service beneficiaries need to come on board as service partners so that we look at the challenges and agree how best do we improve the services amidst the existing challenges we are not going to solve today or tomorrow? I want to thank you for the opportunity.
Thank you. Let's have one here and then we shall end with the city clerk.
Thank you. Protocol observed. Amos Tugumisirize from Rwanda. I have two concerns. There is one who asked the CSOs. There is one question that was brought that as CSOs who are here, they have, the presentation showed that there is long waiting hours, long time, that as CSOs who are here, what are we going to do? I want to inform the House here today that we are here, as Crispo explained, that we did this community-led monitoring. We went to the communities, we went to different stakeholders, we went to different service users. We came out with those incidences and we shared with the service users at community, at facility. That means that bringing that issue here again, mean that in our feedback meetings, it has been an issue that could not be resolved there. So among the objectives why we are here, we need to consolidate and we need to prioritize. So you are here, you are also one of us to answer that question, madam. So you are the one to help us on that question. So you will help us, everyone that is here is going to give us an action on how can we address that. That means that it has been through a different thematic levels to answer that. And to also tell you about that, because if I can tell you a scenario, in our feedback meetings, like at the district level, they have been saying that according to their structures and their budget and their local government, whatever, there are something they could not give us exactly answer or resolve it in our district feedback meetings. So that needed to go at another level. That's why we are here. Then secondly, in our presentation, I wanted to inform you that in the Kigezi region, I think we are here as a region, and in the Kigezi region, we have a serious issue, like my colleague said about the refugees. We also, on this information gap, as you heard, we shared the information gap on available health services. The services are available. The government is providing free health services in most facilities, but there are some special groups in the Kigezi region that are hard, even if the services are available, but they can't afford because of many factors. And among those, like the refugees and we have in Kigezi, we have the Batwa. I don't know whether you have the Batwa, that a minority group of people in the Kigezi region that is dominantly in mostly 3 districts. It has a big percentage, around 6,000. And in Uganda, we have 6,700, and that population of the minority. And currently, there have been a brief that these people cannot be affected by most of the illnesses because of their nature. These are the people who lived in the forest, national parks, and they were evicted by the government of Uganda in 1990s, and in 1995 there was a proper chasing away of these people without compensation, without negotiation. Now they are just there in this Kigezi region. So those people, they have the challenges majorly in this area where we have our data. There have been that gap, like my colleague said about the refugees, also this, but they come from a different geographical locations which are hard to reach, but again, they lack this information gap in these people. Someone doesn't have a home, someone is there, they didn't know that even HIV is a disease. They don't know, when they are affected by malaria, they know that it's because they were chased from their forest. Now, how are we going to solve this? Because even the district pockets, as according to our feedback meetings, they are in hard reached areas. Even if we do more outreaches, are these districts going to afford reaching out to these hard to reach areas? Do they have, like our cow has said, that as you have seen the staffing levels, the percentages, how are we going to reduce or to eliminate this? Thank you so much.
Thank you. Ladies and gentlemen.
Doctor, we have final submission from the city clerk, then we close this session.
Thank you once again. I'm Wasuba Shaban for State Town Clerk. I have 3 concerns. First of all, I want to appreciate Mayanja Memorial Foundation for this activity and all protocol observed. 1, awareness. Among the challenges is awareness, and I would urge you, the organizers, to partner with different medias. We have TV, we have radio, we have councils, we have so many. So this challenge is really solved. If you can partner, they can even give airtime. There are those who are willing, if I'm not mistaken. If you engage them, they give you, and so that people can be aware of all this program. Then secondly is the limited operating hours. I think this is connected to the staffing gaps. Because of fatigue, you might find, I'm not the author of this challenge, but at the back of my mind, I'm thinking the staffing levels will be affected, and health is here. Up this issue, and we reduce on the staffing gaps. Then finally, I've looked at the coverage. I don't know what is your target. I know I see few facilities which are handling this matter. If you can increase, I don't know what, if it's possible, so that every health facility is able to what? To give the services. I thank you.
Thank you. Let me request all of us to raise up and we stretch ourselves. Stretch. You know, we have a lot of inquisitive non-communicable diseases, and make sure you stretch, isn't it? So you stretch. If you see your neighbor not stretching, you know that he's not going to be fit, isn't it? Yes, at least yes, move the legs, move legs. Yes, move legs. Now the trunk, move the body. Thank you. Can sit. Ladies and gentlemen, I've appreciated that today's discussion is actually catching fire, and particularly it is on information. One is that I want to inform you that we are encouraging using a variable structure, particularly the use of VHTs in our communities. Every village has got a VHT. I would love that you encourage them, you support them so that they can reach our communities. Secondly, in some of our facilities, particularly health center 3s and hospitals, we've got TVs. Unfortunately, they are never functional. So I would love that for us, when we do support supervision, let's identify whether we have these TVs in our facilities and see whether they are functional. These TVs were meant to provide health information to our clients. Then lastly, we've got community gatherings, and I would love that every time we have a community gathering, maybe a party, a burial, we could give at least 1 minute to a health worker who is around to give a word, particularly on health promotion. In this way, our communities are going to get all available information. And if the health worker is not there, then the VHT can take lead and talk about maybe reducing on smoking or alcohol or etc. Ladies and gentlemen, how we get feedback, we also have a mechanism of getting feedback from our clients using a client satisfaction survey. Every district is implementing client satisfaction survey, and I would love that you encourage clients to fill that form. It is in different forms. You can use a QR code, you can use a link, but you can also use a paperwork. And this form can be entered directly by the client, or if you use a form, it can be entered by a health worker, particularly if you do not know, if you do not have a smartphone. Lastly, ladies and gentlemen, I want to thank all of us who have been attentive and committed on this session, and I would love to permit the MOH representative to give a comment before I give a final say. Our MOH team, please give us your comment.
Thank you very much, Dr. Amon. I have a few responses, and number one, allow me to appreciate the person who talked about the new and old staffing structures. Yeah, the problem is resource envelope. And we know in Uganda, up to date, the problem is the resource envelope. But also to solve that, allow me inform you that the DHO Buvuma one day or 1 month made an assessment on the human resources in Buvuma. It was to see if actually the staff that are also available are actually active or working, and guess the findings. In the same month, around 15 staff were suspended. Why? We have the problem of absenteeism. We have the problem of they are called leave days. So many of the leave days. So I would want to call upon DHOs who are here that as we try so much to advocate for the resource envelope, also take up your active role of doing the monitoring of the health workers, because this is affecting service delivery. At the end of that day, the health worker comes on Tuesday to work, leaves on Friday, and every day is leaving at lunchtime. I'm not sure what is the recommended time with the district local government to report to work and leave work. So as we advocate for the resource envelope, please try as much as possible to also do the monitoring, but the point is actually taken. The other one is to probably give a recommendation from the findings that were presented. All the people that are seated here have come to listen in to what is happening in their districts. We really appreciate the findings, and thank you, Mayanja Memorial Hospital, for the findings and the initiative. This is a great, great initiative. But also, I would want to add that the DHOs that are here and biostats would want to see what is the contribution that CLM has on the indicators that they are monitoring. What is that direct contribution? So we would love to see that on this particular indicator, CLM did A, B, and C. If it is about prevention, what exactly did CLM do? And we would want to see that if the performance, we are having issues of loss to follow-up, let me say, cases, there are so many. What did we, community-led monitoring, do to improve on the loss to follow-up cases? we would want to see that happening, so that the biostats that are here, they appreciate that because of community-led monitoring, I had 100 cases of loss to follow-up, but now they have reduced it to 10. The biostats and DHOs would appreciate that so much. So next time in the presentation, I would wish we add that, so that it is sounding. But also, to help us triangulate, I understand it is a regional meeting and we are supposed to provide regional data, but also because we have invited different district heads, help us triangulate and tell us that from this district, this is where the problem is actually most happening. If we are talking about absenteeism of staffs, we say it is happening more in Rubirizi. So that the DHO leaves this place understanding that actually in the region, I'm the one having most absent staffs. But when it is generalized, we are not getting exactly where the gist of the matter is. So those are the observations, and other recommendations for MOH, I am going to take them and they will be presented. Thank you.
Thank you for your good remarks and for all of us who have contributed. Permit me thank the presenter of this session, Mr. Nsaimana SDU. Where are you? You remain standing. We are going to face him. All of us, let us face him. I'm going to teach you sign language, isn't it? We are going to thank him for presenting well, isn't it? I'm going to demonstrate once. So look at me. I only demonstrate once because I'm a lecturer, isn't it? We are going to say thank you. Okay? So 1, 2, 3 as you face him. 1, 2, 3. You don't say like this, you say? Okay. Repetition, those who have got retakes. 1, 2, 3. Okay, thank you. We are going to give a thank you in sign language to MOH officer, representative. MOH, you stand up, we want to give you a thank you. I want to make sure that everybody has understood the sign language. 1, 2, 3. So when they give you a thank you, you say welcome. You say welcome. Okay? So we are going to give our director, Mayanja, you stand up, and we are going to say thank you. I want to see whether he has understood how to respond. 1, 2, 3. Thank you. Ladies and gentlemen, thank you for listening. Thank you very much. We are glad for this session, and I'm kindly requesting to hand over, wishing you a fruitful deliberation. Thank you.
Okay. Thank you, Dr. Amon, DHO Ntungamo. I think we can also give him a sign language thank you. 1, 2, 3. I didn't understand that language. Is it riding? This one means what? Welcome. Okay. We are learning today. So we are going to the session of a few of our colleagues are going to share some success stories. From the comments, the team was saying, what is the contribution of CLM? Well, it may be in two ways. We can have numbers being presented by biostats, but also getting feedback from these service users, how it has helped them. On the other side, either livelihood, economic, or even the time being consumed. If they can testify, I think we can also appreciate that there is feedback, there is an achievement, there is a contribution, of CLM. But before they come, our presenter Livingstone, did you have any comments from the team what they shared? Just as someone who presented and all the asks the team had. Do you have one or two comments to put forward?
Thank you so much, team. I was representing the region, and all the views that came out from the members is exactly what also I had to give out. So there's nothing much to add on, but to appreciate all that was mentioned and taken up. How I wish that at the end of the day, we shall come up with action points and who has taken what at the end of the day. Thank you so much, team.
I think out of the 6 people that are going to share with us, we can just have 3 and then we break off for lunch. Isn't it? Let's have 3 people share, then we can have. Let's start with Vincent from Rwanda. And then we shall have Aris and then Taremwa. Then we move for lunch. Then after we shall hear from the other remaining.
Thank you, sir. Mr. Facilitator, I am happy and glad I myself stand here to contribute with 6 districts. I myself, I am the representative of the people living HIV/AIDS Rwanda district on the committee of DAC. I am there. To say that, there is something that I want to say on that. Even if I am that committee, as we people living with HIV/AIDS in every district, as I think, on the budget of the district, they give us 1%. Why can it be enough for us? Secondly, a week ago, we had networks, HIV networks. Was doing very well, very well, but it is no longer there. To say that, I mean that if we had added on 1%, like 2%, we can again and waken up our networks. Dear coordinators from other districts, we should be voice or voiceless comes from the word advocacy. And all the members that I am here, we should be the voice of the voiceless. Thank you very much. Remaining, Ross and Vincent, the representative of people in HIV/AIDS, Rwanda district.
People are saying that are you also part of the team that Amos mentioned? He said they are what? The people living Batwa. Batwa speak very well like you. All of them. You are not.
I am not remote, but I am among them because they are neighbors.
Okay. So Amos, next meeting, bring us one of them. Let's hear from Aris.
Thank you. And by the name of Bira Alice, as a service user, in other words, I'm a TB survivor. Me, I will thank the CLM. It has done much things for us. Before it came in, we had a long waiting hours on the line, which has been talked about all the time. Do you know how it comes? These people, when we reach at the facility, they isolate us, people with TB. They will take you under that tree, then they work on those people with the other sicknesses, malaria and other things. They will take you under the tree. Maybe someone will forget you that you're also there. You come and ask the health worker that also you are there, who will tell you that you first wait. I'm still working with these people. I thank this CLM. Since it came in, at least these people, they are seeing us as emergencies. When you reach the facility, at least they are climbing our faces. When you reach the facility, you will see the health worker coming to pick you from the line and serve you. You go home. Number 2, this CLM has changed the attitudes of some health workers. Sometimes these people, they could quarrel with us. Even will ask you where you got TB. And also you don't know. You ask yourself, and you start fearing these people. You can even end up leaving the drugs behind. But since these people talked to them, at least they have changed their attitudes. Number 3, this CLM has created awareness of services delivered at the facility. Some of us, we could think that maybe when I have TB, that is the only service I will get at the facility. I could not know that maybe they will test even malaria from there. But these people, they told us that when you have malaria, you go and they test you. And I could not know that when I'm on anti-Bs, they will also test me. Again, they will get my sputum. They told me that they do test me after 2 months, 5 months, and 6 months until I get cured. That one I knew it. Number 4, this CLM has created awareness on human rights. Sometimes I could not know that also I can talk to the nurse when the nurse has quarreled with me. He will tell you that even you extend from her when giving you the drugs, that's because you're coughing. But nowadays, since these people, they came in, those people at least they can see us as if we are human beings. But before we had that problem. And we could not know that there is a suggestion box at the facility. That thing, we didn't know it. But since this CLM came in, we know everything. Thank you very much for all that services you are offering to us.
Okay, let's give her a hand clap. Thanks for sharing. Let's hear from Tarema Isinjuro.
Thank you very much. I'm Talema Albanias from Isinjiro. I'm also a service user. So before CLM, before it came, we used to have very many problems at Mabona facility. Because there is one day, I still remember, I went there, I had no money, and then I said, let me go to a government facility that I can get help. But I reached there, it was at around 2 p.m. In fact, I saw a nurse and I asked. That nurse said, no, you will come tomorrow because we have already closed. So when I tried to, at that time, I looked for where to go and I failed, but I had to go buy some tablets, then I went back. Coming back the following day, because I had just to ask very many things on the people who were there. So that nurse was looking at me as a problem because she heard what I was asking. Because I said that how comes that the hospital, that it can close at such an early time, and I'm sick and you are telling me to come back tomorrow? What if I die? So when I said that the following day, the nurse was not in need of talking to me. But then I had just to get attitude of saying that I will never go back to that facility. So one time I heard that the nurse had been taken, then I had just to go back. But then when I reached there also, things were not good because they could just, in treatment, they could just write you medicine and they give you Panadols, they give you these small medicine, and then they tell you to go and buy others, and they show you their own clinics, because the people who were working on the facility were also having their own clinics, and they say we don't have medicine here. You know, the government doesn't bring us medicine. So I kept knowing that in government facilities there is no medicine, and you will never go there to get any medicine. So after, when CRM came, it was last year, then they came to us in the community. I attended their meeting. Then they tried to tell us that we need to go to government facilities. And we had just to tell them what was happening there, and we said we cannot go back there. But at that time, the one who was teaching us told us good things about the facility, and told us that when you give your points, we are going to take them, forward them, and then one time we will see the facility staff changing. So afterwards, when we went there, then I found some of the things changing. I found now this time, when you go to Mawona Health Center 3, those people welcome you well, which was not there before. So that's why I say that CRM, when it came, it brought a new thing to the community. And then when they came even to us, to the community, they also gave us awareness of knowing that also we as patients will be having our own rights to talk to the staff. And when they tried just to tell us all that, then we got to, we are not knowing that there are boxes where we have to put our views. In fact, I was ignorant about it, but this time I want to tell you that when I go to the facility, even these days I have been sick, but I went there, I saw there is a change. So that's why I say that CRM, if it continues like this, I know that everything will have to do it to be okay. Except the thing that is still there is the few staffing. Because you can go there, you cannot get, you be in need of a health worker, but to get is not easy. But when we tried to ask, now this time they told us there are very few. So we asked the government, mainly the Ministry of Health, to add us more workers so that we can get health services. Then another problem that we were having, but that one is, yes, is still there, but not at a very bigger way. It is called availability of drugs. Drugs are still few on the facilities. So that's why we say that, but when we tried to ask on the drugs, now this time, the other time they could give us only Panadol. But this time now, they can give you, they can add on you, and then you get to know that some of the drugs are not there because they tell you in a polite way. But before you could ask for a drug, and they talk rudely. But all this was done by CLM. So that's why we say, then another thing that we were having, it was community sensitization. Because of what I told you, very many people were no longer going to the facility. Because they were knowing that when you go there, you are not going to get any service. We had already even spent too much money in clinics, just not going to the government facility, knowing that we are not going to get what we want. But when CRM came, they tried to come, they sensitized us. Now this time, when you go to Mabona facility, you find there are queue of numbers at Mabona, except that there are some of the things that are still not there, mainly because of few workers. So we ask the government to make sure that they add us, because without workers, then we have to continue not getting the services the way we want. Then before, I told you that some of the workers were talking rudely. And some of them, even when you talk, they could not attend you. And we are not knowing that we have our rights, or we have where we can go to talk about that. But when these people came, community-led monitoring, when they came to us and they sensitized us, they told us what to do, that we give them our points, then they will have to forward, and we see a change. And this time, I think we are seeing a great change, except that they are not all 100% at this time, but there is an improvement. So that's why we say that community-led monitoring has done a lot to us, and we appeal to the government to coordinate with them and give us the services, so that they can give us the services very well. Thank you for that.
Okay, thank you for those sharings that we've heard from our colleagues. I think we can really clap for them. As we prepare to break off for our lunch, we have a task. From the presentation, but also the discussion we've had, we need to have some actions that when we come from lunch, we should be able to get measures. Some of those unresolved system issues and structural issues. What I noted was there was a very key question from one of us. The CRM monitors, the service users, when they speak up for these services at our facilities, do they stand a risk of being isolated in our communities or at facilities? How are they protected so that they can speak up? This is something that is very key. Some of us could have come here and they are able to speak, but others who are down there and they can really speak some of these things have not been able to do that. How do we design an interventional strategy of protecting them so that we can have many of them come up and speak up? This is something that we need to discuss as a team. There was also a key take home on the linkage. How do we link this CRM to the existing structures? We have the DAC, District AIDS Committees, we have the TPC, we have the mentioned makers in the districts are, including the politicians, how do they act of the period and say this is an issue that was raised in this forum and it has been. Finally, we can have unresolved issue escalated up to the national. For those like how Carl said that some issues may be beyond the district's level. And then let's say, how do we measure the contribution of CLM? This is something we need to think about as we break off for our lunch, and others that you've also raised. So after lunch, we shall have the rest of the three colleagues also share the experiences, and then we can have some of these actions that you noted. We see how to get them solutions or strategies on how we can move forward. Javira, is the team ready? As they check for our services, if they are ready, we can have one or two comments from us as we break off. I have an opportunity of only 2 comments. You raise your hand and I give you a microphone. Yes. You want to come in front? You want to stay there. So be attentive and listen very well from the Executive Director of Support Disabled Uganda. Or turn your faces, all of you. She's asking all of us.
A good afternoon to everyone, ladies and gentlemen. I greet you once again, and I'm very happy to see you. My name is Betty Chogavirwe, and I'm the Executive Director, Support Disabled Uganda in Tungamo District. And as ACDU, we welcome you all. How are your lives? It is very important that God has given us health, and we need to thank Him. And my friends, Dr. Mayanja, you have been so kind to us that for the first time, we don't know, but you have involved an organization that involves persons with disabilities. He's requesting members to appreciate the Mayanja community. Thank you. As SDU, remember, I am deaf, that's why I'm using sign language. I think you can all see me. So I can speak a few words, but hearing is a problem. But I'm fine. Am I not fine? So some people look at me and they are surprised, but I'm fine. I talk to people. I'm normal like any other person, but the only difference between me and you is communication. So that's why I'm saying that this touch on disabled people with disabilities was so important, and I was privileged to be part of the group that was picked to be supported. So people with disabilities, we normally say that nothing for us without us. So that means we need to be involved in most of these activities that you also do. But you can only do or help us when we are also involved. Most community-based organizations, they have good policies about PWDs, but they don't actually implement to know how can we help them, how can we work with people with disabilities. So they always gamble. But when you want to help a person with a disability, you have to bring them on board, and you work together in communities, in different activities, in workplaces,
and so many other things. But when you don't involve them and you say you're helping them, then there is a problem. What do you think? So this kind of support to us is so good, and we need to always think about involving people with disabilities. That's why SDU is general. It is not focusing on persons with disability, but because the ED is the person with disability, we can't also fail to have them on board. So just like SDU is also focusing on the general population, we are requesting that other people also, you try to include persons with disabilities. Before CLM came in, there was a lot of fear in communities. So many communities, especially to us persons with disabilities, they are never open. Of course, for some reasons, but during those community sensitizations engagements we have had, so many people have opened up and so many people have been helped because of the coming of CLM. That's why some people can come here, stand, and they are able to share some of the information because of the CLM coming in and increasing those, community engagements. We have been able to share, we have been to engage different people, and now at least the fear has at least gone down in our communities there where SDU operates. And I want to thank my team. I am not working alone. Maybe the SDU team and the other people we have been working together in inclusion. I really want to thank you so much. And it is important to have good health for actually every person. I don't want to thank to spend a lot of time, but to thank CLM for the continuous support. And we still request you to support us so that we can touch those people whom we have not touched, so that we can continue the sensitization. And maybe you can also support other CBOs so that we have, so many people touched in our communities. I want to thank you so much, and may God bless you for God and my country.
Okay, thank you, Betty, for those remarks, and thank you for listening in. I noted the whole team was really attentive. At least you've picked something. When she says like this, it means all of us, including you. So I think you can stand up, and we are going to pray in sign language, and then we move for lunch. And Dr. Amon knows how to pray in sign language, or I can assist. Let's pray and we go for lunch. Mu izina rya Patri, rya Mwana, rya Mutima Urukwera. Amina. Amina. Hey, all people say Amina. Thank you. Let's meet after lunch. Yeah. We have, I think you can leave your belongings on the table. They will be safe, except the phones and the wallets.
As they are waiting for lunch. Okay, as they are going for lunch.
The other things,
please,
I think you can move with them. We shall be back, I think, we can take lunch for 45 minutes. Greet each other. The link we shared on our WhatsApp, they are coupons. They are coupons we are taking for lunch. Let's have coupons. Where are they? Joseph, get coupons and give people. Let's have coupons and we go for lunch.
Okay, people who are following ninjira namurebe shitukuzamo tuza lunch. Tuza lunch kandi ningezo kubona ba organizers. Ndio ningezo kubona abamwabo ba organizers zo kujya kigambe cyo bagamba. Then at least mubone information iri kusinga. Bafatwe TV mugumizemo no subscribinga mukoratire. Then liking ango yona subscribe follow omukoro gucyagendo misho then tekaba za church bazar nanka lunch ite tantu ko kantu tuzagireke live ninga shokureta byenyine bya birone bitambura then tugumizemo for now ninza kugezaho ndete omugiga ningashi Dr. Mayanja wenyine agere message yagamba mwamutaka mbwineje ko kantuza kumbona omu full swing ya Dr. orije ntendo gire cyo wagamba abarebe akurigire function ko meeting ijana yamuru rimiki urubona rwenda ubundi Dr. Mayanja utu na organizing embere juni muruno mureba shana kayongere atutere kishani cece kintu okugira ngo mugire cyo mwacengo kusinga cyumwareba we bare muno aka tukabaheruka bari bakabara munonga tukareba bina bacuruhura bahi enyuma ho imyaka enyuma nice kimwe iki hati kantu agaruka twakireba muherugwe imyaka nabwo cece kintu nikihabisha ntaka kuburize kibuze niki kiturumweki
mbone abarukundeba basebona abanyabo ito turyaha na abebembeza ku rwo mu districts mukaga ezo mu region yitu ya Western.
Yes. Okay, yes, abantu nbana jana baramusaho mukuru ko kukimanya konka tugumiza mu nembozo yi
districts mukaga ntungamo Rubanda, Isingiro, Kasese, Rubirizi na Mbara City. Turyaha ahabwa ehurero kugira ngo obuherezo butwereza kubo ibyabamagara tubaha abantu tubaragura konko bwiro bwingi abantu bundi mugisha na kutugambira kutukubaragurira tubaherezo buhereza burungi ejo akakagisha obwiro bwingi kakataro nkamwe hati ogumushomo ningashije meeting eriyaha eriyo neyoreka okwa abantu abitwerezo buhereza bakutuyamba kumanya kutukubaherezo buhereza kandi tukabukora kurungi bakurabiro mu kutugambira akugira twonka kamunije mukashishi kandi tukiriro kurebwa haruki ningashika basket aruhu ubundi kuko n'umugamba nitwe kubi mbwenu ebyo ntubikora twaiza kubabuzo kwa kutekateka batuhereza entekateka yabo tugarakayo tugamba nabo aha community nangwa tugenda tugaraka tugamba nabashaho kandi tugamba na district omuri emyanya egeshatu buri yomwe nayihamu icyashime kuba nakora nahinduraho mwene bagira ngo abashaho nabagamba ubundi baretera abarwire baturu ushahanyinja hirwaro hateki kintu die cyo na agenda agamba nabo ningashi ini cyaje wa facility kandi bigaruka mbatanaka kuraba rwire mangu barakuturaho so ati kibe cya die ningakibe cya ini cyaje wa facility tutyo burevu konka cyaturetaha district mukaga no kugira ngo twena the district tuijaha turebe ebyakwa bitarakoze la community bikija byaza facility ebya facility bija byaza a district hati district turiya region nibihe bitakorwa ha district ebitwenda tahamwe nke region n'indwe tukabitwara national level ebishime kwane bitukura ombara bitwerezo byamye tukujya nawo rwire bonka communities tukora nazo facilities ezo kandi hati ne region district zijaz ziganire nibike bitushimiye kugenda nabyo tukabiteka hihanga Ministry of Health ekareba icyo gukora bene kintu nkakimwe muri ibyo abashaho okuba batari bingi aha facilities n'abashaho baki kimanyisa ngo ecyo Ministry of Health nebasa kukireba mu gihe abashaho twakumara muri katugambe n'aba Health Service Commission nangwana na Parliament ubundi katera ka sente hatutunga kutwa hereza abashaho abandi bakatunga sente bakabahereza imirimo bakaba binjya amafacility bakaragurira abarwire munshi cyato leta ninyibaza abona beja
nibajya
kandi abaryaha hariho chief administrative officers bakaba ba districts abakurebera abakozi hariho ba DHOs abaryaha bakurebera ibyo magara hariho abakurebera ibya community district community development officers hariho abakora biostatisticians n'abakwija abakuba mbateka ibitukora inamba tukuzikora mu karmagezi mu computers bakatuhira mu kubyemerire bakanu batugambira tuyine na civil society aba civil society organizations community based organizations as unizikora eje kintu cyo kweta community led monitoring ninga shi community okwicho kutugambira kutwaza kuchimikwa tuhindura imitwaro zemibi tukakora imitwaro zomirungi tuyineho n'abantu abatungira ubuhereza ababiri mbatungo ubuhereza omumarwa rago barebere kwindukaho wiha eje nkoreija bamba gambo buhereza bakusharinga ninga shwa kugamba mitwarize ya amarwa ruga kutwaza hadi ahabu umutendero kandi umutendero gukuhendera nukugira ngo no mutendero gwa ministry egwinemu obugwingi kandi ningira ngo tukugenda mesho nikija kwika hingi tikiri mu western region honka buri region ziyonchikora ninyenda kwebaza abakwempi hanka global fund nyenda kwebaza abakuzirebera nka taso yitu ya Uganda no bakutesente konko muri ebyona tuyon tukora imirimo ninge myoga yo Ministry ya Health. So I thank the leadership of Ministry of Health, the Minister, the PS, Dr. Diana, Dr. Cheng. Certainly I also thank the where we are working and for his visionary leadership, and thank everybody, and thank you very much for being here. And the media, the fatwas here who are here, Fatwe, we also thank you participation and involvement.
Naraho nare tusime ya na sima yaterane suma tindiyo nindeba Mayanja barano bakureba bayango ukababura
nyon kisha nagarwa bantu bitu kandi kubahereza ubuhereza ntuhereza ubuhereza mu miringo mingi nyon kashara munajya ntanze kuhereza ubuhereza ahi ekizobukiri naho no mu communities
then hati ece kimwe abene mutambuza muri koti yade muri nkahi kikakumanya
kandi tutambuza ikintu kikwate nibyo magara tukantu tuine sentes go mu global fund and taso Uganda hati tukantu kora bya TB na malaria hati bibikiruho na neshikiruho aka eginenkora yo kuhereza ubuhereza burungi abarwire bendwara nyingi TB na malaria nabo barumu hati gindo kuhereza ubuhereza burungi aba kwetaga ubuherezo and those are called service users.
We have used this language because we are in the region where many of them...
So we can go English. We are here as we convened this meeting as Mayanja Memorial Hospital Foundation with support and funding from Global Fund being coordinated through TASO, and here it's a region of a meeting of 6 districts, and that is Rubanda, Ntungamo, Kasese, Rubirizi, Isinjiro, and the city, which is Mbarara City. And so there are 6 units who are here, and we have the COW, DHO, biostatistician, DCDOs, and also civil society that implement the mechanism called community-led monitoring. And Ministry of Health is represented here as well, but also other stakeholders. Community-led monitoring means that this is a method where the service users, the service beneficiaries or service users are able to contribute to the way they are being served. They can actually tell you that, we are tired of your language, it's rude, we are tired of waiting long at health facilities, we are tired the way health workers are handling us. With this method involves meet communities, get information from them, use the information to synthesize it and get what they were talking about. And when the communities give feedback, then we go to a community, tell them this is what you gave. They say, yes, this is true. Then we go to facilities, that's what they think about you. And the facilities develop actions, communities develop actions. And from there, we go to the district. And the districts also hear and put in mechanisms or actions that mitigate issues. And finally, we are here at the region because all the 6 districts or administrative units are here to compare notes, learn lessons, but also to develop a regional action plan for which of those issues they are not able to manage, then they are further forwarded to the Ministry of Health for further action. The one case that, for example, is under the mandate of the ministry is low staffing levels. Maybe when this issue comes from the region, goes to the ministry, then the PS, the minister, they are able to have dialogue with, take the issue to Parliament, advocate for more funding to recruit more healthcare workers. So finally, thank those who are participating. This model is purely a model that is done by civil society. We don't influence processes. They do this work and technical assistance, financing, guidance. So working this together, and certainly the implementing partners, the staff of the foundation, MMHF, the district stakeholders downwards up to community, and finally the media. You guys, you've been doing a great job. Thank you, and God bless.
Okay, man. I think we have been with you since the day one.
Yeah, I highly appreciate, and I'm excited that you are here and we continue serving the people. As Honorable Tusime, certainly we serve different environments, and I'm comfortable contributing to the welfare of our wananchi, and if they are better, we are all better, and they are able to vote for the leaders.
Okay.
Thank you.
Okay, thank you. I think you have heard the officer, the way how he has tried to explain the point to point. Then now, which kind of disease that is affecting the region? The most disease?
No, these are our common infectious diseases. Certainly they are TB, diarrhea, pneumonia, but there are also other emerging, what you may call diseases, which people don't necessarily pay attention, and we call them non-communicable diseases. In other words, there are diseases which don't spread from one person to another through contact or greeting, and these are called non-communicable diseases. In particular, hypertension, pressure, diabetes. These are on increase, and there are also these accidents which are really on increase, a high mortality rate. But in terms of what we're trying to work out here, the model or the methodology encompasses better services for whoever has that problem. So that's what I can say, and I think that's it. Thank you.
Okay, I think in time ahead we shall talk to him and we bring his details, of which people who don't know him is Mayanja, Dr. Yeah, if I'm not misquoted, he's among the stakeholders of Mbarara, if you know. Isn't so?
We've been in Mbarara for a bit of a while, and we've made a significant contribution to the development of the region, the city, and the communities in southwestern and central Uganda.
Wow. Okay, thank you. Dr. Diana, bakura musana so much or engaging and he's our follower.
Oh no, Dr. Twine Diana is a very active PS, focused and forward-looking, and some of us who are
the university turi kuhereza eby'enshoma graduates byona kare from turugahihona hono mu ihanga. So mugume nitwe mugumize muno mutufollowinga Facebook, YouTube, TikTok, Instagram, Threads, obo twarire muna YouTube ninga shena za exezo zona kirungi muhijana mutukuratara. Of course tinkari mwa kusima timu yanje lya kamera Faiswari turi nawe na nabandi na nabana bari mu production tutambuzo mu rumo mpora so imwe cyanyu muturinde mpaka terarjeho mugumize muntu mutuwacinga mwebare munonga yeah.